we have used two drug-coated balloons in 6.5% and 3 drug-coated balloons in 2 patients. We have used Mehra's angiographic classification to classify the ISR. The most common class was class 2, which was seen in 39% of patients, followed by class 4, then class 3 and class 1 in 14%. The most common drug-coated balloon we used was agent, which is the paclitaxel group, followed by Prevail, again paclitaxel, and protease, again paclitaxel. We have used sirolimus only for 4 number of patients. The results procedure related, sir. The procedural success was defined by ability to deliver drug-coated balloon at target site, transit time as recommended. In our series, success rate was 100%. Procedural safety was excellent with no instances of perforation, tamponade or need of emergency CABG. TB3 flow was achieved in 98.4% with no significant residual stenosis. Procedural complication we have seen in one patient, that is TB2 flow in 1.6% of patient. In hospital, mortality occurred in one patient, that was secondary to access site complication. In follow-up, rehospitalization was seen in 9 patients. 8 admissions were because of ischemia. 1 was admitted for heart failure. There were no cases of stent thrombosis in 6-month follow-up. Reintervention was done in 8 patients and 7 patients presented with target vessel failure, that was 11.2%. And major MACE occurred in 16.2 patients, and most commonly it was seen in diabetic patients with complex ISR lesions. So these are the details of reintervention. So out of our 62 patients, 8 needed reintervention, 7 needed reintervention for the same vessel where we have used DCB previously. Out of 7, 3 patients presented with NSTEMI, 2 with unstable angina and 2 with stable angina. For one patient, patient presented with ischemia, but the vessel was de novo vessel, so it was not the same vessel. This is just a total cases where we have used drug-coated angioplasty, out of which 62 were ISR and 83 patients we have used DCB for de novo vessels as well, and the results are same. So it can give us the data of DCB in de novo vessels as well. So my take-home message is, the study demonstrates that drug-coated balloon angioplasty is a safe and effective modality for treating instant restenosis. Observed MACE rate of 16.2%. It aligns with the previous trials such as PACOCAT and PEPCAT, which establishes DCB as a viable alternative for drug-eluting stent in ISR. Optimal lesion preparation and drug-coated balloon selection remain key to success. Limitation include it is a single-center design, small sample size, and imaging we were able to use only in 24%, and lack of angiographic follow-up. However, the favorable 6-month clinical outcome highlights the practical utility of DCB angioplasty in routine practice. In this prospective single-center study, drug-coated balloon showed excellent procedural safety and favorable 6-month clinical outcomes with 84% of patients asymptomatic, low intervention rate, and no stent thrombosis.
Good study, Smita. This is the in thing today.
Yes.
You did an intravascular calcium
Image.
score, imaging.
Yes.
So suppose there is a calcium score is high. Do you still recommend drug-coated balloon and avoid stent?
No, sir.
Then you put in a stent.
Yes, sir. After optimizing the lesion, we'll go for stent if there is a calcium.
And why you don't want to use a stent?
Sir, again, it will. Basically when we are having in small vessel and all, so the vessel diameter will be less with stent, and we are putting something foreign body. Again, risk of ISR will be there. Re-ISR risk will be more when we are putting a stent. With drug-coated balloon, that risk is less.
And what is the risk with only balloon?
Sir, the vascular recoil will be more, and again, neointimal hyperplasia and all will be more without drug-coated balloon.
What
Only
about
angioplasty.
spasm? Suppose you withdraw the balloon and there is spasm.
We'll wait for some time, sir.
So there were 8 patients who had restenosis.
Yes, sir.
They required stenting, or you could again balloon it?
No, sir. Again, we did ballooning only. We did not do stenting in those patients.
And stenting also interferes in the endothelial function.
Yes, sir.
Plus, in future, if major artery is involved,
yes, sir. Then
you cannot bypass it.
Yes, sir.
Any other advantages of this apart from the cost factor? How much the cost factor comes down avoiding stent?
Sir, in procedural, no, but in follow-up when we are giving drugs like dual antiplatelets and all, that cost will come down with drug-coated balloon.
I was your age, this was the thing. There was no stent. And there were specialists who were still practicing. They were just doing balloon and with fantastic results.
So,
And
but this is drug coated balloon, sir.
yeah,
So,
so they were doing plain ballooning and
Yes.
still they were doing very well.
yes,
Doing very, and the drug code is the same as you use in the stent.
stent, yes. But in drug, normally whatever stents we have now, they more are like limus groups, sir. And in drug coated balloons, we are most frequently using paclitaxel. Less frequently now sirolimus and all is coming into picture, but whatever available is they are more of paclitaxel.
So you recommend only ballooning, or you recommend stent which is absorbable, or you recommend stent which is permanent? What is the statement that you want to give? You must have done so many patients, 80,
60.
60.
Sir, if for instant restenosis, we recommend drug coated balloons, sir. And normal native vessels, still that is a part of second study, sir, where we are comparing stent with drug coated balloons, even de novo vessels. So there also, when the small vessel like less than 3 mm or 2.5 mm, there again the role of drug coated balloon is there, sir, compared to drug eluting stents.
And if there's a calcium, then
No, sir, calcium will always go for stents.
thank you, Smita. Thank you.